I've performed over 2,000 brain and spinal surgeries in my career. I've operated on patients whose neurological damage was caused by tumors, by trauma, by vascular disease. And in that time, something I've seen repeatedly, something that took medicine an embarrassingly long time to acknowledge, is damage caused by medications. Pills prescribed with the best intentions, pills that millions of people over 60 take every single day. Medications that, over time, could unexpectedly affect brain health rather than supporting it. My name is Dr. Marcus Reeve. I'm a neurosurgeon, and today I'm going to tell you about 5 specific medications that carry serious neurological risks after 60, risks that almost never get covered in a standard 7-minute appointment. My intent is to empower you with information, not to cause alarm. All medications have important functions. I strongly advise against discontinuing any medication without consulting your doctor. My aim is to inform you about important questions to raise with your physician. After 60, your brain processes medications differently than it did at 40. Your kidneys filter more slowly. Your liver metabolizes drugs at a reduced rate. The blood-brain barrier becomes more permeable. Medications that once stayed primarily in the bloodstream now cross into brain tissue more readily. And the aging brain, with its reduced neuronal density and diminished repair capacity, is less tolerant of chemical interference than it was 20 years ago. Now watch me till the end, because you need to know about these 5 pills. Let's start it. Here is the first one. Statins. Roughly 1 in 3 adults over 65 in the United States takes a statin. Atorvastatin, rosuvastatin, simvastatin. The names change, the mechanism is the same. Statins save lives. For established cardiovascular disease, the evidence is clear. I am not disputing that. But there is a consequence buried on page 14 of the prescribing information that most patients are never told about directly. Statins block something called the mevalonate pathway. That pathway doesn't only produce cholesterol, it also produces coenzyme Q10, CoQ10. Studies consistently show statins reduce blood CoQ10 levels by 30 to 50%. For the brain, CoQ10 is critical. It is the primary antioxidant within mitochondria, the cellular machinery that powers every neuron. When neuronal mitochondria are running below capacity, the effects are recognizable: mental fog, slowed processing speed, memory difficulties that patients often describe as feeling as though their thinking is stuck in mud. Beyond energy supply, CoQ10 depletion increases oxidative stress in brain cells, a process associated with changes linked to accelerated cognitive aging. Some researchers have specifically connected statin-induced CoQ10 depletion to increased susceptibility to certain brain changes, though the evidence remains ongoing. The question to bring to your doctor: should I be supplementing CoQ10 alongside my statin? And what should my levels look like? CoQ10 testing is not standard practice, not in the guidelines. CoQ10 supplementation is available over the counter. 100 to 200 milligrams daily is the range most studies have used. That conversation has almost certainly not been initiated on your behalf. Now the other one. Long-term proton pump inhibitors, omeprazole, pantoprazole, lansoprazole. Roughly 15% of American adults take them. Many for years, some for decades. Proton pump inhibitors work by suppressing stomach acid. The brain connection comes through what stomach acid does for nutrient absorption, specifically vitamin B12 and magnesium. Vitamin B12 requires stomach acid for absorption. Block that acid long-term, and you block B12 absorption nearly completely. After 60, your stomach already produces less intrinsic factor, the protein needed to absorb B12. Add a medication-induced deficit on top of an age-related one, and the result is B12 deficiency developing quietly over years. What does B12 deficiency do to the brain? It damages myelin, the protective sheath around nerve fibers. Without adequate myelin, nerve signals travel slower and less reliably. The neurological symptoms of B12 deficiency are specific: cognitive slowing, memory difficulties, tingling in the hands and feet, and in severe prolonged cases, significant and lasting neurological effects. Magnesium is the other critical loss. Proton pump inhibitors deplete magnesium with prolonged use. Magnesium is essential for the function of over 300 enzymatic reactions in the body, including the regulation of NMDA receptors in the brain, the receptors most critical for learning and memory formation. Magnesium deficiency is directly linked to increased risk of experiencing seizures, increased migraine frequency, impaired sleep quality, and reduced cognitive function. The questions to bring to your next appointment. What are my current B12 and magnesium levels? Is there a plan to eventually taper off? And if long-term use is necessary, should I be supplementing methylcobalamin, the form of B12 that absorbs under the tongue, bypassing the stomach entirely? Here is the third one. Anticholinergic medications. This is the most urgent category on this list, and the one most consistently underappreciated by patients. Anticholinergic medications block acetylcholine, one of the primary neurotransmitters involved in memory, learning, and cognitive function. This category is enormous. It includes certain antihistamines sold over the counter for allergies and sleep. It includes certain bladder control medications, certain antidepressants, certain medications for Parkinson's disease, certain anti-nausea medications. The anticholinergic burden, the cumulative effect of taking multiple medications with anticholinergic properties simultaneously, has been documented in multiple large studies as a significant risk factor for changes in cognitive function and memory. A 2019 study published in JAMA Internal Medicine followed nearly 300,000 patients over 10 years. It found that people who had taken anticholinergic drugs for 3 years or more had a 50% higher risk of developing dementia. For specific categories, bladder drugs, antidepressants, the associations were even stronger. The mechanism is direct. Acetylcholine is essential for the function of the hippocampus and the prefrontal cortex, the brain regions most critical for memory storage and executive function. Blocking acetylcholine long-term can chemically influence cognitive functions crucial for maintaining independence. The critical issue is that many patients take these medications without knowing they have anticholinergic properties. Diphenhydramine, Benadryl, is the most common example. It is sold as a sleep aid, as an allergy medication, as a component of many over-the-counter pain and sleep combinations. Millions of older adults take it regularly. Its anticholinergic burden is among the highest of any commonly used medication. The question is not whether to continue prescribed medications. That is a conversation with your doctor. The question is whether you know which of your current medications have anticholinergic properties, and whether they have been reviewed together as a combined burden on your cognitive function. This one I think make you wow. Fourth one, Warfarin. Warfarin has been prescribed since the 1950s. It remains one of the most prescribed anticoagulants in patients over 65 for atrial fibrillation, deep vein thrombosis, mechanical heart valves. Warfarin prevents dangerous clots by blocking vitamin K. But there are two forms of vitamin K, K1 and K2, and warfarin cannot distinguish between them. Vitamin K2 activates a protein called matrix GLA protein, whose specific job is to prevent calcium from depositing in arterial walls. Without active K2, calcium drifts, and one place it deposits is inside blood vessels, including the small cerebral vessels that supply brain tissue. Studies comparing long-term warfarin users to patients on newer anticoagulants show significantly accelerated vascular calcification in warfarin users. In cerebral vessels, this calcification reduces vessel flexibility, impairs cerebrovascular autoregulation, and is directly associated with an increased risk of certain cerebrovascular events and vascular cognitive impairment. I have seen what surgical observations of affected cerebral vessels. The calcification changes everything about the operative environment. More critically, it changes the patient's long-term neurological trajectory before surgery is ever on the table. The questions to bring to your doctor. Given the newer anticoagulant options available today, is warfarin still the optimal choice for me? And has anyone measured my cerebral vascular calcification burden through a calcium score or relevant imaging? And the last medication, calcium supplements. This is the hardest one for me to discuss, because I recommended calcium supplementation myself, confidently, routinely, for the first 15 years of my practice, and I was working from incomplete information. A landmark 2010 meta-analysis in the British Medical Journal examined 15 randomized controlled trials involving nearly 12,000 patients. The finding? Calcium supplementation without vitamin K2 and D3 was associated with a 30% increase in cardiovascular event risk. The brain-specific mechanism is this. Supplemental calcium without K2 and D3 enters the bloodstream as a sudden, concentrated surge. The body cannot efficiently direct it all to bones. A proportion deposits in arterial walls, including cerebral arteries, creating calcification that stiffens vessels, reduces blood flow, and directly increases the risk of stroke and vascular dementia. Meanwhile, calcium dysregulation at the neuronal level is one of the central mechanisms of neurodegeneration. Neurons maintain very precise internal calcium concentrations. When calcium management fails, as can happen with excessive supplemental calcium in the context of K2 and D3 deficiency, neurons undergo a form of stress that can contribute to protein processing changes observed in Alzheimer's disease. I told elderly patients to take calcium for years. What I should have said was, take calcium with K2 at 100 micrograms as Mk7, and with D3 at minimum 2,000 IU. Wherever possible, get calcium from dietary sources, dairy, leafy greens, small fish eaten with bones, and use supplements to fill gaps rather than as the primary source. If you are currently taking calcium supplementation, do not stop abruptly, especially if you have documented bone density concerns. But bring this conversation to your doctor immediately. Let me bring this back to where I started. I want to tell you about a patient I'll call George. He was one of my neighbors, 72 years old, retired professor. Referred to me because his wife was alarmed by cognitive changes that had developed over 18 months. Word-finding difficulties, confusion with sequences he had managed automatically for years, increasing emotional flatness. His testing showed significant decline in processing speed and memory function. His imaging showed early changes. When I reviewed his full medication list, I saw it within minutes. He was on a high-dose statin. He had been taking diphenhydramine, sold as a sleep aid, every night for 3 years. He was on a PPI for 18 months and had never had B12 or magnesium checked. His B12 came back critically deficient. While we're on the subject, I'd like to ask you something. Do you find the smell of B12 pills tolerable? I used to use them myself and didn't like them at all. But isn't the smell what matters, right? Anyway, we made targeted changes, not dramatic interventions. We added CoQ10. We started sublingual methylcobalamin. We identified an alternative for his sleep difficulties that carried no anticholinergic burden. We worked with his primary care doctor to implement a gradual PPI taper. 6 months later, his processing speed had improved measurably. His wife described him as back. The word-finding difficulties had significantly diminished. I cannot say with certainty which intervention drove the improvement. It may have been all of them working together. What I can say is that for 2 years, his cognitive decline had been attributed to aging. 2 years before anyone looked at the combined neurological burden of his medication list. Here is what I want you to do before your next appointment. Write down every medication and every supplement you take, every dose. Then add 3 words at the top of that list. What am I losing? Every medication involves a trade-off. Statins lower cholesterol and deplete CoQ10. PPIs suppress acid and block B12 and magnesium. Anticholinergics manage symptoms and chemically impair acetylcholine-dependent memory circuits. Warfarin prevents clots and blocks K2-dependent protection of cerebral vessels. Calcium supplements protect bones, and without K2 and D3, may calcify the arteries that supply your brain. None of these trade-offs mean the medication is wrong for you. They mean the conversation is incomplete without them. You deserve the complete conversation. Share this with someone over 60 who manages multiple medications. And tell me in the comments, has a doctor ever discussed the neurological effects of any medication you've taken? I want to know what those conversations look like in practice. As I mention at the end of every video, our brain health is really important, and that's why I'm here. Take good care of your own brain too. It is who you are. The content in this video provides general medical insights derived from current neuroscience and clinical practice. It should not be considered personalized medical advice. Always consult your healthcare provider before making any adjustments to your medication regimen.